Hello, everyone. Thanks for joining. We will get started here momentarily. Just give everyone another minute to join and then we'll get started. All right, looks like we are good to go. Hello, everyone. Thank you so much for joining us for the July 2023 PQA Quality Forum Webinar. My name is Amanda Ryan. I'm the Director of Education here at PQA, and I'll be the host for the webinar today. Our topic today is exploring food and nutrition security's impact on medication use quality. Before we get started, I would like to go through our housekeeping items. First, please do send your questions to us. You can do it while the presenters are speaking using the Q&A feature that you will find at the bottom of your screen. And our speakers will address as many questions as we have time to after their presentations today. And then in addition to that, the webinar recording and then also a PDF version of this slide deck will be available to PQA members in the week following today's webinar. And you'll be able to find that on the Member Resources Library section of the PQA website. And then in addition to that, we will post the webinar recording publicly on PQA's YouTube channel. So if you'd like to share it, go back and view it later, please feel free to do that. And then finally, I would like to encourage everyone to please complete the quick 1-minute survey that will populate once the webinar ends today. We do use your feedback to inform our future programming. Before I introduce the speakers to you today, I will share some brief background with you on food and nutrition security and its impact on medication use quality. In September of 2022, the White House Conference on Hunger, Nutrition, and Health brought stakeholders together around the goal of ending hunger and increasing healthy eating and physical activity by 2020, so that fewer Americans experience diet-related diseases from things like diabetes, obesity, and hypertension. The conference's call to action included more than $8 billion in commitments to accelerate programs to end hunger, improve nutrition and physical activity, as well as reduce disparities. In alignment with national goals, PQA is expanding its work to address food security and its impact on medication use quality. PQA is focused on food and nutrition security because it impacts a person's ability to access medications and also to use those medications safely and effectively. You can see here on the slide 3 ways that food and nutrition security impact medication use quality. First of all, individuals who do not have reliable access to affordable and nutritious food are more likely to be non-adherent to their medications. Secondly, food insecure individuals often have to choose between buying medication and food, and those individuals are more likely to report getting sick because they cannot afford their medications. And then third, beyond impacting access to medications, food insecurity also impacts the management of chronic disease because nutrition, of course, impacts the disease itself, and then also the medication effectiveness to treat those diseases. So in today's webinar, we are going to explore how food security can impact STAR measures, how organizations and their partners can increase access to nutritious food, and also we'll hear about some interprofessional models for delivering personalized nutrition services. And with that, it is now my pleasure to introduce our 2 speakers to you today. First with us is Catherine Macpherson. She is the Senior Vice President of Healthcare Strategy and Development, and also the Chief Nutrition Officer at Mom's Meals. Also with us is Jim Kirby, who is the Chief Commercial Officer at Kroger Health. Thanks, Catherine and Jim, for joining us today. And with that, I will turn the floor over to Catherine.
Thanks so much, Amanda. It's really a pleasure to be here with you today. And thank you for that introduction. I'm a dietitian by training, but adherence is very near and dear to my heart. And the work that PQA does is so important. And, you know, as all of your pharmacists and organizational members. So I did spend a few years at a large national retail pharmacy leading both immunizations and medication adherence. So very familiar with the work that you do. And again, adherence to medication is so important. All right, so I'm going to introduce Mom's Meals, the organization that I'm representing today. So Mom's Meals is a very mission-driven organization, and our mission is improving life through better nutrition at home. And we've been proud to do that for 24 years now. So if you can believe it, you might think the concepts of food as medicine are, somewhat new, or, addressing unmet social needs, like access to healthy food, in healthcare. That, it's not so new. So Mom's Meals has been delivering medically tailored meals for 24 years now. We got our start in Iowa. We're still headquartered in Iowa. Today, we have a national footprint. We reach every address in the country. So anywhere there are patients or members of our health plans that we work with, we're able to deliver medically tailored meals. We have 3 USDA inspected kitchens. We cook all of our own wholesome food in one of those 3 kitchens, and again, deliver our meals nationwide. We are the largest medically tailored meals provider in the country, and we are a healthcare partner. So that's really, the bulk of our focus. We do have, direct to consumer sales just on momsmeals.com, but most of our work is through healthcare organizations. So today we partner with all the large national health plans in the country in one form or another. That could be through their Medicaid, their Medicare Advantage program, et cetera. We partner with a lot of the regional health plans, a lot of Blues plans, as well as community-based health plans. Our program types are many. So meals support people who are aging in place, or people with disabilities who want to remain independent in their homes for as long as possible and avoid institutionalization. We offer meals post-discharge to help people rest and recover and get back on their feet as quickly as possible, but importantly, to avoid readmissions as well. We support more care at home that's happening today, like hospital at home, even skilled nursing at home. Chronic condition management is one we'll focus on a lot today. I've got some great case studies for you that demonstrate some real patient impact through medically tailored meals for helping people to better manage a chronic condition like heart failure, diabetes, kidney disease, etc. We have a lot of maternal and child health programs with the big focus on maternal health and mortality in the country, but also importantly, food insecurity. And thanks, Amanda, for that great setup about the why. Why should we, why is there a link between, food and medication adherence? Well, that's very strong, and we'll talk about some of that evidence. All right, but in addition to health plans, we also work with hospitals and health systems directly. We could work with state and local governments, and I mentioned that self-pay program as well. All right, so let's get into the food. This is my favorite part, being a longtime dietitian. The food that we eat is so important. It is, food is medicine, but food is also, it's just health. What we eat every day does go into the building blocks of our cells, and that's essential for the efficient and regular function of our bodies. So at Mom's Meals, our medically tailored meals ensure that people who have chronic conditions are able to follow the dietary guidelines for that chronic condition very easily. It's very convenient. So as you know, when you're doing your MTM and you're counseling your patients about change and adaptation of their current habits around medication, all behavior change can be challenging. What we're doing with the fully prepared meals that we offer is really lowering that bar to the difficulty of change to make it as easy as possible. The meals are refrigerated. You just receive the delivery at your front door. You stack the meals in your fridge, you can see them there, and then you just heat and eat. So 1.5 minutes to 2 minutes in the microwave. All the meal trays that you can see there have an entree and a side portion. That could be the vegetable, or there could be a fruit crisp that's heated. All of those trays have a FDA nutrition facts panel, just like you would find on any packaged food. So very familiar, easy to read. People with chronic conditions will be used to looking for certain nutrients. That label's on there, but the good thing is they don't really have to read it too closely, because if they are getting the diet, the menu that is specific to their chronic condition, all of those nutrients will be within the recommended guidelines. And so what menus do we offer? We have 9 condition appropriate menus at Mom's Meals. You can see general wellness. It just follows the dietary guidelines for Americans. A diabetes friendly menu that has an upper limit on carbs, lower sodium. That's going to be appropriate for somebody who has heart failure, who has hypertension, etc. Heart friendly, which is lower in sodium, fat, and saturated fat. Renal friendly, this is going to be appropriate for people who have stage 4 or 5 chronic kidney disease or who have end stage renal. So again, that can be a very challenging diet to adhere to. A lot of the nutrients that are important, like phosphorus or even potassium, don't typically or always show up on food labels. Potassium is a new one that's been approved, but phosphorus, it's not on there today. And so that can be really challenging for patients. So this is a very, very helpful diet. Cancer support, these are higher in calories and protein to help people undergoing chemotherapy or people who are malnourished and just need extra calories. We often use these in our pregnancy programs as well. But we have vegetarian, gluten-free, and even pureed. So for people who have dysphagia or for people because of medical conditions who have trouble swallowing, or even people who have aged, in aging, may lose teeth as they age and can make chewing a challenge. So we have that important pureed diet as well. In addition to our medically tailored meals, Mom's Meals is again, food as medicine partner to many healthcare organizations. And we offer other nutritional services as well. I'll just highlight some. We do have oral nutrition supplements. So for people who really have trouble getting all of their nutrients through food, they can drink an oral nutrition supplement between meals. We also offer nutrition education with our dietitians. We have produce and pantry boxes as well. And so, kind of from end to end with, kind of medically tailored meals being right there in the center, we do offer solutions to help organizations with their food as medicine strategy. Now, let's talk a little bit about choice. We know that choice is so important in what we eat. We strive to be culturally sensitive at Mom's Meals. We have a full kosher and halal menu, for example. We want to ensure that across our 60 to 70 dishes that appear on our different chronic condition menus, that people have adequate choice and they're able to select, each and every meal that they're going to receive in their delivery. Again, that's crucial. It's, if you're just kind of, given something for lunch or given something for dinner and it's maybe has mushrooms that you don't like, or there's pork and you don't eat that for religious reasons, that's going to be a no-go for you. And so food is very personal. We all have our preferences, and, at Mom's Meals, what we've learned over the years is that choice and selection is so important. That's going to lead to greater consumption, less waste, which is so critical in the food industry, and a greater impact of the nutrition. So we know that it's so important that 96% of the clients that we serve do choose to customize their meals. I should also note that in addition to the entree portion, which you see here, that's everything that's going to come in the tray. So let's look at that middle. These are all photos of our actual meals. This is our Korean style meatball dish with brown rice. We create all of our own sauces, so they're lower in sodium. That's our own barbecue sauce. We create our own ketchup. So there's a lot of flavor, but they are, again, lower in sodium. And then you can see the steamed broccoli. What you don't see in the photo are the side dishes that also come with the meals. So our side dishes include things like a fruit cup, an applesauce, cheese stick, oatmeal raisin cookie, whole wheat roll. So those are meant to round out the meal, or they can also be eaten between meals as snacks. All right, so Amanda really set us up good here, but I'm going to move into some of the evidence around, that very powerful combination of a nutrition intervention and how that can help drive outcomes around medication adherence. So there are a lot of studies that show a link between food insecurity and cost-related non-adherence. So some of the characteristics that come through in the research, who does this impact most? It's who you might anticipate: people with lower incomes, people who don't have prescription drug coverage, so their out-of-pocket costs are going to be very high, people who are on multiple medications, so even if they have a lower out-of-pocket, those kind of adding one upon the other is going to be a challenge. And then people with multiple chronic conditions. And who has multiple chronic conditions? We know that chronic conditions are typically going to develop as we age. And so people over age 65, that's the Medicare population, are typically those with multiple chronic conditions. So of individuals over age 65 in the US, 80% have at least one chronic condition. I'm sure you all know that already, but just a reminder. And older adults who are in need of food assistance were the ones who were more likely to restrict medication use due to cost. So those are folks who likely have that polypharmacy and the multiple chronic conditions, right? So that's a little bit more about the why for you. I want to talk for a minute about quality. That's kind of PQA's focus, but if you think about health plans, and that's a big partner of ours, quality is very important to them. In the Medicare Advantage program, there are the star ratings, and the star ratings determine the amount of rebate dollars that a health plan is paid from CMS. And those rebate dollars go towards supplemental benefits for their members, like meals programs. Those meals programs, medically tailored meals, are typically a supplemental benefit. Other things like vision, hearing, dental, transportation, all kinds of benefits are paid for out of rebate dollars. And so it's really important that a health plan can achieve a high star rating through good quality care, and with that have adequate dollars to create a comprehensive and attractive benefits package to their prospective Medicare Advantage members. And so how pharmacists can really play a role in driving quality for your health plan partners is through kind of those Part D measures, which are the drug measures. So if you see down below, taking diabetes medication as directed, taking blood pressure medication as directed, and taking cholesterol medication as directed are really important Part D measures that go into the STARS calculation. And all the work that you do is so crucial there. But a way to further enhance Part D measures can be through nutrition. And so I'm going to provide a few examples of case studies where we do see that medication adherence goes up when medically tailored meals are introduced as part of the plan of care for patients. All right, so a little bit more about Mom's Meals. In our history, we have been a partner to research organizations. We want to help build a strong evidence base for food as medicine and for medically tailored meals in particular. So we've been part of 5 published studies. That's more than any other medically tailored meals provider out there. 3 NIH funded, 1 funded by a health plan and 1 funded by a research institute. But at any given time, we have about a dozen pilots going on. And so I'm going to talk to you about some of the important, not all of the research is published. We know how high a bar that is to clear to get in the peer-reviewed journals. And a lot of good pilot programs and research is being done, particularly with health plans. That doesn't often get published. So there's not usually an IRB process and that critical review. But so what Mom's Meals likes to do is to create case studies. And we like to share these at different meetings and webinars like this forum. So I'm happy to share 2 of those with you here quickly. The first one is with Inland Empire Health Plan. This is a health plan in the Central Valley of California, east of Los Angeles. So it's a more agricultural area. It's where a lot of our fruits and vegetables come from. And so this started in June of 2021, a 6-month pilot for members who had heart failure. They were all dually eligible, meaning they were eligible for Medicare, so they were 65 and up, and also eligible for Medicaid, so low income. And we worked with a behavioral psychologist at the health plan who is an expert in behavior change, which was really wonderful. And he helped to design the protocol for the pilot. So it really started out with just changing that nutrition environment. 3 fully prepared meals a day from Mom's Meals were delivered right to the front door. And from there, the second phase, the next 8 weeks, we started to taper the fully prepared meals. There were 2 fully prepared meals a day, and we started to deliver produce and pantry boxes along with healthy recipes. At the same time, they were getting support from a Mom's Meals registered dietitian throughout the program. In the last phase, the last month of the program, we went down to just 1 fully prepared meal a day and continued with the produce and pantry boxes. So we were moving people toward that transition of, doing it on their own. And so I want to provide just a snapshot of the outcomes. So, about 304 meals per member, 11 produce boxes, 6 pantry boxes, about 4 nutrition education sessions per member completed over the 6 months. We also had interdisciplinary care team meetings with the nurses who were available from the health plan as well. All right, on the next slide, these are the outcomes I wanted to share. What we saw after the pilot was a 50% reduction in ED visits and a 50% reduction in hospitalizations. This was amazing to the health plan. These are frequent flyers, very often going to the ED because of exacerbation of their heart failure, which typically happens when you're eating a high sodium diet, which is what is, kind of very common among convenience foods. If you think about going through the drive-through or, kind of heat and eat items that aren't medically tailored, we can see a lot of sodium, and that can lead to that fluid retention and trips to the ED. So, and as part of this program, which is a really wonderful side effect for people better managing their heart failure, was weight loss, because we did change the diet. So we do impact body weight. So an average loss of just about 6 pounds per person over the 6 months. So a very slow, sustainable rate of weight loss. Huge cost savings for the health plan, a cost savings of about $1.8 million in total. And that was a 25% reduction in total cost of care. But here's sort of the headline for all the pharmacists, that medication adherence did increase. So we saw PDC for medications go up from 33% to 100%. So that was wonderful. These were individuals who maybe weren't as engaged with their nurse previously and weren't hearing some of the messages about medication adherence, and were maybe making trade-offs between food and prescription medication costs. All right, the last, I'll just take 1 minute here and talk about the last case study. This is with the Health Plan of Nevada, which is a United Healthcare Medicaid plan in the state of Nevada. This was a diabetes pilot program. And Mom's Meals was already working with this health plan on their post-discharge meals program, but they said, people love the meals. They've been very effective at helping people to prevent readmission. We think these could play a role in our diabetes management program. So their original program was 12 weeks of calls with a nurse, and they decided to add meals to the program to see if they could enhance outcomes and also enhance engagement in the program. So individuals with high A1C were targeted because they were out of control with their diabetes management. All right, so we had 125 people ultimately enrolled in the meals portion of the program. So somebody needed to complete 4 calls with their nurse, and then they were eligible for 8 weeks of meals during that full 12-week program. So the average starting A1C was 10.86. You can see we had a really nice distribution of individuals who were in the program as well, and the average age was 48 years old. And what we saw in individuals who completed the 8-week meals program was pretty incredible. So their A1C came down over this time by, almost 2 percentage points, which on a, percent calculation basis is a 17% reduction in A1C. This is incredible. This is what, we know we can do sometimes through medication, but, helping people with their eating habits as well. These things can really go hand in hand. And if, we've tried tweaking medications a couple times with, maybe varying results, this is another way to really help individuals learn to eat for their chronic condition and achieve success over time. And some of the outcomes, what we did see was more engagement. So with meals becoming part of a program, there was an immediate value for these Medicaid members. And the call conversion rate, or the call, successful call completion rate with a nurse doubled, went from 11% to 21%. People were picking up the phone. And the average length of time that somebody stayed engaged with their nurse, went up by 44%. So instead of staying engaged for about 8 weeks with their nurse, they were staying engaged for 18 weeks, even beyond the 12-week program. So that was a huge success. And so the last slide I have for you is that, again, huge cost savings here. People were not going to the hospital as often. Their diabetes was better managed. Their A1C came down. So that translated to a 30% decrease in the total cost of care. Hospital stays down by 82%, observational stays down by 44%. And importantly, the prescription costs increased, which indicates more fills, more medication adherence. It increased by 27%. Even with that increase in the preventative spend on medications, overall, the total cost of care came down. These are exactly the kind of results we want to see, and exactly why food as medicine is really taking off. It's because of all this great work and research that we're really starting to see, I think, attention from sort of the highest levels in our government, even the White House, hosting that wonderful nutrition summit in the fall of last year. So more to come here, and thanks for your interest in this area. And with that, I'm going to pass it over to Jim. Thank you.
All right. Thank you, Catherine. And thank you, PQA staff, for inviting me to be part of this very important and timely discussion. My name is Jim Kirby. I worked for Kroger Health for about 2 decades, and I wanted to share a little bit about what Kroger Health is doing and the importance of incorporating an interprofessional approach, including dietitians, into our pharmacy practice, and just addressing nutrition as part of the holistic care that we're providing as pharmacists. Okay, so it's no secret that America is sick. We pay a whole bunch, I think, top of the high income earning countries in this world, but we're ranked worst in terms of quality. We spend over $4 trillion a year. Over half of people have at least one chronic condition, 40% have 2. Chronic diseases are responsible for most deaths in this country, but the good news is that we can reduce that risk through good nutrition and access to healthy foods. So why Kroger? Why did we get involved? Well, part of it should be intuitive because of what you see here on the screen. We sell food. We're a large grocer in America, serving 35 states. Currently, we have about 3,000 stores. 2,300 of them have pharmacies, and in total, we have about 22,000 healthcare providers that include pharmacists, pharmacy technicians, nurse practitioners, dietitians, physician assistants, and the like. So we feel like we have a real opportunity and really a responsibility to the public and to the communities in which we serve to do something around this problem of chronic disease and obesity. Pharmacy as a profession stepped out during the pandemic and really saved this country during the time when we were needed the most. And all the while before the pandemic, and then certainly after the pandemic, we never forgot, though, about this epidemic of obesity and chronic disease that was plaguing us. And the pandemic highlighted the role that pharmacists can play in combating some aspect of public health. But now it's time to shift everybody's eye to look at what we can do around chronic disease and prevention. Part of the reason why this hasn't been solved in the past is because of how complex it is. I dare say that diabetes or hypertension is easy because those diseases are not. But nutrition is incredibly hard, mainly because it's so personal and it's influenced by so many different factors that are intrinsic and many of which are extrinsic. So this was a infographic published in 2008, and I thought it nicely illustrated the complexity of what influences us to eat certain foods and what outcomes that we get from poor nutrition or good nutrition. But on the bottom left, you can see the individual factors of what we think about food, our behaviors, the lifestyle that we live, our genetics, where we were born as far as zip code or even block can influence what we eat and our outcomes. To the right of that are kind of our close social networks with family and friends. And then you go up to the upper left, and now you start talking about the places in which we live. Do we have parks and sidewalks? Are there good schools and opportunities for our children to grow and develop? And what does our restaurants look like in fast food? Are there grocery stores, or is it just mainly gas stations? The proverbial food deserts that exist, or care deserts, that influences a ton of how we view health, how we view our ability to attain health, and our ability to access care. But then on the right, these are the macro things that are around us. And if you think about tobacco and smoking, this was one of the strategies that helped drive down tobacco use in this country, is that we leveraged the lawsuit from the tobacco companies and use those dollars for a public education campaign, dare I say, demonizing tobacco smoke and really educating the public about the negative health consequences of smoking. And so those systems, as well as policies that were put in place around, you can't smoke in restaurants anymore, or planes, and which I can't even imagine being on a plane and having people around you smoke, but that was the case not so long ago. But those policies changed the cultural expectations and just the way that people behaved, so that it made the individual choices easier. So going back to why does Kroger feel like they have this responsibility? I just drew a red box around all the places in which that we play. I mean, we are a healthcare provider. We do produce and distribute food. Our private label brands could be considered one of the top 10 CPG or consumer packaged good companies in the country if it was considered as its own company. We do a lot with retail marketing and media with those CPG partners. And we're also an employer. We're one of the largest employers in the United States, with 460,000 plus employees that either work in our stores or offices or in the supply chain. So huge opportunity for us to influence many of these things. Now, we can't directly change individuals, but we can help change individuals' behaviors, at least. So we can't change the genetics, but we can change behaviors, and we can help provide social support as healthcare providers, so we can influence what people are putting into their bodies and help combat this chronic disease problem. Food as medicine means many different things. And you will even hear in the industry that people call this food is medicine now instead of food as medicine. And we at Kroger like to stick with food as medicine, but we view it in this particular way, not trying to alienate any sort of food, and not trying to make food as medicine some elitist concept that isn't attainable for all. But for us, it's really about this dedicated, educated, and personalized approach. With personalized should be like capitalized, bolded, underlined, to eating and enjoying food so we can live healthier lives and prevent illness before it starts. It really means, boiling it down, that there's a time and a place for all foods, even Oreo cookies. Maybe not kale chips, because I don't know that they should have a time and a place for anywhere, but that's just because I think they're disgusting. But other than that, there's a time and a place for all foods. And some foods, and especially like decadent desserts, that you would say, come on, Jim, that's not food as medicine. It could be, like, if that's something that reminds you of the dessert that your mom used to make you, and evokes these fond memories, and really creates this positive energy and outlook, that is food as medicine. Or that you share that dessert with your family, and you pass on those traditions, and you're cooking with your son or your daughter in the kitchen and teaching them how to make that one dish for their kids one day. That's all food as medicine. So it doesn't have to be just produce as is pictured here, or just lean proteins, no fat, low sodium. It is those things too, but it's not just those things. There's a time and a place truly for all things. Similarly, as the definition changes and is viewed differently by many, the application of food as medicine can be very different. And we can talk about the customer experience and more preventive tactics of food as medicine, all the way to that deeply personalized patient experience that where something like where Catherine was talking about, that medically tailored meals fits in, or medical nutrition therapy by a dietitian fits in, that I'll talk about here next. But first, I'm going to talk a little bit about how we can impact the consumer. And much like OTC labels, which I think the latest stats, when I used to teach this back in the day to students at the University of Cincinnati, was that only about a third of people even read the labels on OTC meds, and only about a third of those even understand all the things that it means. Pretty much the same sort of stats that apply to nutrition fact panel information. People don't understand them if they're even looking. And who by God can calculate like the amount of calories from the carbohydrates when it's the grams that are listed, or the percent daily value that's listed on there for a 2,000 calorie diet, but my caloric requirements may be not that. And so how do I create that ratio and figure out what's the right amount of calories and macronutrients that I should be consuming? So it is very difficult in and of itself if you pay attention to it, and it's very difficult to apply to your very specific situation. So what we've done to try to help solve part of this problem is create a food rating system. It doesn't solve the personalization aspect of it, but it does look at each product and categorically rate it as green, yellow, red. But then it also creates an ordinal score from 0 to 100. So it helps people to understand where it rates on the healthiness scale. It's meant to be a comparison within particular categories. So you should not take quinoa, as shown on the screen here, as an 82 and try to compare that to Oreo cookies or to yogurt or broccoli. It's not meant to be that way. It's meant to be within like the dried pastas. In this case, how does 82 rank? Is it good, or is there a 90 that I should be striving for? Now, this is probably not the best example, because quinoa in and of itself is pretty healthy, and same with this packaged cut fruit that I have on here on the right. But it does also help with the packaged fruit example, show customers to say like, well, hey, I don't have to eat fresh fruit to be healthy, and I don't have to worry about spoilage or carrying around produce and getting it bruised or taking it with me on the go. Like there are options that I could pack in my kids' lunch or take with me to work, and it will last on the shelf for a couple of months in the packaging. And as long as I'm not choosing the one that's in heavy syrup, this is in actual juice, or it could be in water, that I'm getting a really high opt-up score. So it helps also debunk and normalize some of those myths and fears that are out there. But the other thing that we do is we look at these product scores, and then we average it out over the course of time and look at one's purchases in aggregate over 1 month or 3 month or 6 month period. And we can compare that to the average Kroger shopper. And therefore you can see that, are you getting better or worse? And how do you compare to the average Joe shopper? Now, this is where I would like to personalize this as we continue to evolve this product, where you could take the benchmark or the target and you could personalize it to your store, or maybe to your zip code, or maybe you put in your things about yourself, that maybe you have cancer and you're trying to put on you're just trying to pack on as much calories as you can. Your target opt-up score probably looks very different than somebody else's, or your zip code, you may be starting at a lower place, and so you shouldn't be compared to the average Kroger, because maybe you guys are starting, those shoppers are starting from a lower place. So let's look there and start to make incremental improvements. So huge opportunity for opt-up, for us to understand not just products and nutrition facts panels, but then also behaviors. Now the question is then what do you do when you have this information? Can we incentivize individuals to make better choices? And that's really where we're operating now, is to say like, okay, we show you a product that has a particular opt-up score, but let me show you the same or a similar product that has a slightly better opt-up score, maybe 2 or 3 points higher, that you're likely to buy. And if we do that, then, and we perhaps incentivize you, or there's a coupon loaded for it, and you start to buy that, and you start to do that over the course of time, you can improve your overall opt-up score rating. Now, the cool thing about opt-up is that it's not just a consumer tool. It's actually an impact measure and a way that we can influence products and how they're manufactured. So I'll talk a little bit about that. So impact measure, as I was kind of alluding to with my population example there, that we can look at how healthy purchases are over the course of time in a particular community. We can also use that in research and say, like, how well are patients progressing when they're interacting with our dietitians? They've had 6 visits. How well are they progressing? And I can see the changes in purchases and how it's getting healthier over the course of time. And you may say, well, so what? Their opt-up score is improving. They're getting healthier. They're making healthier purchases. What does that really mean? Well, we've done a lot of work in the background where we're associating this with health activation indices and even with total cost of care reduction. So independently of improvement in blood pressure, independently of improvement in medications, if we just change the nutritional intake, you can impact total cost of care. And we're able to now show that with an actual number versus relying on patients to do 24-hour food or 24-hour recall or complete food frequency questionnaire, which inherently is loaded with a whole bunch of recall bias and are not specific or precise. So this is a way for us to get really granular and understand it. And it democratizes nutrition as a measure as well, because physicians, they don't understand how to talk to patients about nutrition. I mean, anyone's been to the doctor and maybe your weight has creeped up a little bit. Your doctor says, eat more fruits and vegetables, try to get more exercise, those sorts of general pieces of advice. But now if you had an actual number, just like a blood pressure or a blood sugar, you could have conversations and say, hey, I see your opt-up score is improving. And oh, by the way, I see your blood pressure is improving or your cholesterol is improving. And it starts to create that association in patients' mind to say, okay, what I'm putting in my body is translating into better health and better control of my chronic condition. But the thing I get really excited about is how suppliers are coming to us and saying, hey, I want the healthiest cereal bar or the healthiest protein bar in the category. How do I get there? And so we analyze it and we show them where their score is compared to others in the category. And they come back and they know what they do to reformulate. They do the taste test and all those things so they don't compromise on that, but they're able to improve their opt-up score. Now all of a sudden they have the healthiest bar in the category and watch their sales grow from there. So if we do that over and over and over again, now we have consumers demanding and buying, even if they don't recognize it, healthier foods, and we've created a more positive food environment by just working with the suppliers and working upstream. So it's a really cool application that we're excited about. But to get from the consumer tool to the other side of that continuum, we have to leverage the expertise of the dietitians. And pre-pandemic, we had our dietitians in store, but for obvious reasons, we pulled them out. And now that they're providing telenutrition services across the country, they take self-pay or they can bill many insurance plans. Their patient care process is very much just like the pharmacist patient care process. I've come to learn it's really fascinating. I don't know if that was by design when pharmacy designed theirs, because I think ours came second, but there is amazing overlap there. But the interesting thing about our dietitians compared to dietitians in other practice settings is that their retail lens, that they're not only doing the typical assessment and setting goals for patients, but they're really diving in deep to social determinants of health, what their readiness for change is, what their preferences are, do they work third shift, how many people are in their household, what brands do they typically engage with, what sort of budgetary constraints do they have, what sort of culinary skills do they have and knife skills, how many times do they eat out, all sorts of things like that. So they really dive down deep into the specifics around the food and the grocery store shopping experience, which is different and unique. We studied the impact of our dietitians in a study called SuperWin. It was just published last year in Nature's magazine, which I don't know any other retailer that has been published in Nature's magazine, but it is a very high bar to overcome. But we compared to two strategies, one which was 6 in-aisle personalized education visits with a Kroger Health dietitian to control, and then also adding in the layer of using online shopping tools like OptUp, like recipe builders that were available online, in combination with those 6 visits, and combine those together and compared it against control. And our measure of success was looking at adherence to DASH diet, which, if you're not familiar with the way DASH diets are, adherence is scored, I'll just share with you that a 5-point increase is where you see dramatic and statistically significant improvements in overall mortality, cancer risk, systolic blood pressure, diabetes, all sorts of the major chronic health conditions. And when you looked at individually strategy 1 and strategy 2, pretty impactful results compared to control, but control even improved 6, and that's because we called standard of care was still one NMT visit with a dietitian, which that's not really standard of care. So the fact that we were still able to see statistical significance, the fact that the combined strategies against control was still statistically significant in about that 5-point increase in the DASH diet score that is the best in class. We were pretty proud of this. So we are going to continue to study this, look at longer term results, and see how we continue to iterate and achieve even better results. One of the last studies I'm going to mention is the one that we have going on with PQA on the value-based care pilot for diabetes. And we're looking to revamp the way that we do chronic disease management and do it in an interventional bite-sized way, so that we're not like doing this big, heavy program enrollment at the pharmacy counter, but that you first start with a welcome visit, and then we start to break down in bite-sized chunks. Let's look at adherence. Let's look at gaps in care. Let's look at the full medication profile. And including, we look at, should this person be referred to the dietitian? So we built an electronic referral system that our pharmacists can refer to the dietitians, and we've seen over 450 referrals so far just in this program. So this is a way that pharmacists can interact and refer patients to the interprofessional expert resources. If you don't have dietitians in your organization, there are dietitians available, or there are other community-based organizations that everybody should be familiar with that's practicing in a community to know where to refer patients that have these needs. The last thing I just want to touch on is an opportunity that's emerging. About half of all Americans are covered by some sort of government-funded health plan. And of those that have Medicare, about half now have Medicare Advantage, and more Medicare Advantage, like it's growing at 121% year over year, offer these food and nutrition and OTC benefit cards. And they'll do things like limit to, you can get funds for produce in the store, to you can get anything in the store but tobacco and alcohol, or sometimes that they combine it with education and other incentives for individuals to buy healthier foods. But the key thing for us to know is that these cards exist, by S3 or Nations Benefits or Income, but there's a lot of retailers that are starting to drive awareness to their shoppers that these cards exist, and they get funded on a monthly basis, most of them, some of them on a quarterly basis. But if they don't use the funds by that time, they lose them. So it's really important for us to make sure that they are using those funds. And it doesn't take the place, if they're a dual beneficiary in Medicare and Medicaid, that they still may be eligible for SNAP. So this would make their benefit even go further. So get enrolled in SNAP and then access these benefits. And as the SNAP funding has gone down dramatically this last year, this food benefit card funded by their plan may supplement some of that loss. So it's a huge issue to help address food security. And the last thing I'll say is just there's a resource that we developed with the American Heart Association about interprofessional care with retail dietitians. It's available now through, I think, mid-2024. It's 1.25 hours of continuing education. So I'd encourage you to check it out for more information on the topic and the value that dietitians can bring overall to the care of the patient. And with that, I will turn it back over to Amanda.
All right, thank you so much, Jim. Thank you, Catherine, for sharing your work with us today. We appreciate your perspectives. We are going to move on now to Q&A. So I would like to remind the audience, if you have a question for our panelists today, you can use the Q&A feature that you see at the bottom of your screen to submit questions to us. We do have a little bit of time here for Q&A. I'm going to start with one for Jim, and this is related to PQA. So given PQA's focus on improving medication use quality, what is the specific job the PQA has to do here related to evaluating, supporting, and promoting the quality of food and nutrition security programs?
First of all, I don't think it's allowed that PQA staff people are allowed to ask questions of the speaker, but I will allow this one. I think that part of the answer was already in the question, and I think the evaluation of the programs and help promoting research is key. I also think that there's still a lot of work. I mean, a lot of the perspective I presented, it was because I'm a grocery pharmacy, right? I have advantages. I have the food that others may not have. And we have dietitians that others may not have. But I think, one, it's about helping to identify those community-based resources and educating pharmacists on the awareness of it. Two is figuring out, how do we screen for nutrition insecurity at pharmacy as part of the care that we provide. There's a lot of interest in social determinants of health screening, but I don't think it's very clear on how best to do that in a way that's not intrusive to the patient, unexpected to the patient, and will be adopted in the busy workflow of community pharmacy. So figuring out what that looks like, where it fits into workflow, then studying the results, and then having the training and resources available is a great role I think PQA can play.
All right, Jim, we appreciate your insights there. Thank you so much. Catherine, I'm going to throw this question to you, and then Jim, if you've got some additional insights you'd like to share, feel free to chime in. So Catherine, you mentioned at the beginning of the presentation that you do have a background in retail pharmacy. So our question is related to that. And it's, how can retail pharmacies collaborate to advance food security programs?
Sure, no, that's a great question. I would say, first of all, be aware that food and nutrition benefits, and Jim highlighted this as well, are becoming more and more common as part of a health plan's benefit package for the patients that you're working with. So about 70% of Medicare Advantage health plans do have a meals benefit today. So that's a post-discharge meals benefit. So if you're seeing someone after discharge, you're doing that med-rec post-discharge, ask, do you have a home delivered meals benefit available, through your health plan? You can always call the number on the back of your insurance card and find out if you have that benefit. Typically the health plans are going to have some type of outreach from a case manager or automated outreach after discharge to let somebody know that they have this benefit, but not always. The benefits are operationalized in very different ways by health plan. So I think that's a great one, just to be aware that these benefits are available, and to, if you do see someone who's struggling to pay for medications, you may have an understanding that they have income limitations, and food could be an issue for them as well. Jim mentioned the healthy food card benefit. That is becoming a more and more common benefit in Medicare Advantage, and also in some Medicaid, managed Medicaid health plans as well. So individuals can use that card to purchase healthy food, and that can help. Again, we know that if somebody's getting, that really good nutrition, that can improve their adherence as well. And so, again, just being aware that there are benefits out there, and helping to direct your patients to tap into those nutrition benefits would be great. And just to echo Jim's comments around, kind of that social needs screening, I think that we are starting to see that become a quality measure. We are starting to see more movement in that area. and it is a social needs screening and referral. So again, that is not something that is being asked of retail pharmacies today, but it could be in the future. It could be an additional value that you could add to your health plan partners. Just some thoughts there, but I know how busy it is in retail pharmacies. So, finding that additional time with the patient is always going to be a challenge and a balance. So, but great questions.
Thank you, Catherine. Jim, anything to add there?
Well, I would just highlight one of the things that Catherine said is about the link between medication and adherence and food or nutrition security. And while it's somewhat intuitive that if somebody's making decisions between buying food or picking up their prescriptions, that could lead to non-adherence. I don't know that it's always top of mind that when we see non-adherence that we think about, like, do you have food insecurity? Like, we talk about being able to afford medications when we do adherence assessments, but I don't know that we do as good a job as what we could in diving into why they can't afford it. And if there are, I'm going to answer the other question and kind of in conjunction with this, Amanda, asking about how do we help people that are uninsured or underinsured. I think then plugging them into the resources that may be available to them is key. And the uninsured, frankly, the uninsured, frankly, may be easier to identify because you can, with some level of research, you can find out things like, the United Way or the food banks that exist in your area or specific community-based organizations that do a good job and are able to that are accepting kind of new participants in their program. I think it's harder when you talk about the underinsured. And I've looked at some data from US Hunger, and they had about 30,000 people in their database that have expressed some sort of social determinant of health need, not necessarily nutrition. It could have been transportation. It could have been unsafe housing or those sorts of things. But interestingly, 80% of those are commercially insured. So just because somebody has insurance or commercial insurance does not mean that they don't have a need. It does not mean that they're still not hungry, or certainly it doesn't mean that they're putting the most healthy things in their bodies. So we have to challenge ourselves to go beyond to think like, oh, this is only Medicaid, this is only uninsured. It affects everybody. I think that the community-based organizations it's easier for maybe you to identify if they're uninsured where to go, but if they're uninsured, they still may be eligible for those programs too. So and then what's harder is knowing what their insurance company or their employer may offer them, because a lot of employer plans now are starting to put things in place for low-income wage earners. And that's why I mean it's a little bit harder to fully be able to understand all of the resources available to that individual because they're not as well publicly publicized. So yeah, it's not easy. Like I said, if we thought we could just beat diabetes, we would be fine. Like solving hunger and nutrition insecurity is a whole other matter.
Right.
Agreed. I would just reinforce the, USDA nutrition programs again, SNAP and WIC, WIC for expectant moms or moms who are just postpartum as well. We talked about the Medicare Advantage benefits in managed Medicaid. There are sometimes healthy food cards. But more and more often there are medically tailored meals benefits, especially for expectant moms that may have gestational diabetes, may have hypertension with their pregnancy, et cetera, especially those who have high-risk pregnancies. And then to Jim's point, on the commercial side, we are starting to see more interest, I agree, in employers who are self-insured or fully insured, looking at healthy food options for their employees. And it's both from a health perspective, looking to, bring down cost of care, but also an employee, retention strategy as well, that this, it's a competitive labor market. It is something that can be quite attractive as an employee, if this is another benefit that your employer offers.
All right, Jim, Catherine, we will have to leave it there. Thank you so much for joining us today and for that fantastic discussion. We're going to wrap up now with a few announcements. I'm going to drop some information for you in chat. We did get a question about the slide deck. The slide deck will be available in the member resources library for PQA members within a week from today. So that is how you'll be able to access that. But as far as next steps related to food and nutrition security, PQA is continuing to assess the current landscape on this topic, and we are interested in supporting members and other stakeholders in this space, especially when it relates to positively impacting medication use, and the future activities that we'll be engaging in here will be influenced by the evolving landscape. PQA's recent work to address food security as part of our broader strategy to improve medication use quality has included the development of our PQA Social Determinants of Health Resource Guide. We are right now currently editing the 3rd edition of the guide, and it's going to be released in early 2024. It is going to include an expanded focus on food and nutrition security programs. So if you have programs, we would like to hear from you. If you would like something for us to consider, if we're including in the guide, you can submit them to our website. We have a deadline of Tuesday, August 1st. The link is in chat. You can access that. You can also email us at the address there if you have any questions or if you need assistance with that submission. And then next, PQA has launched an updated medication use quality CE program. 6 courses are currently available in the program, and those include courses like Healthcare Quality Foundations, Measurement Program Foundations, and then a newly expanded course on equity and social determinants of health and medication use quality. Those are available in the PQA Education Center right now, and then the entire program, including the certificate version of the program, will be available by late summer. And then PQA does also invite you, our members, to attend our 3rd and 4th quarter stakeholder advisory meetings. So please save the dates for Wednesday, August the 16th, as well as Wednesday, October the 25th. Those will take place from 1 to 1:45 p.m. Eastern Time. And these are members only staff hosted meetings where PQA staff will share measure development and maintenance updates, and will also share with you some engagement opportunities related to PQA measures. Registration information is going to be available in the member resources section of the PQA website. And you can also watch your email for more information here coming up soon. And then finally, please make plans to join us for our next Quality Essentials webinar. That will be on Thursday, September the 21st from 1 to 2 p.m. Eastern Time. This webinar will be focused on PQA's polypharmacy measures. Registration information will be available as we get closer to that date, so please watch your email for updates on that as well. And with that, I would like to thank you all for joining us today and have a great rest of your day.